Hello and welcome back to GI 101. My name is Dr. Adriana Lazarescu and I am your host for this episode. With me in the studio today is Dr. Dan Sadowski. So Dan, over the past couple of episodes, we've been discussing the mechanism of action of various prokinetic drugs. What are we talking about today?
Well, Adriana, today I would like to talk about opioid-induced constipation.
Oh good, this is a timely topic as there are some new therapeutic developments for these patients.
So I'd like to start with a case that I think illustrates the problem. This was a 60-year-old male that I was asked to see with a significant history of constipation for 6 months. And on average, he passes one stool every 10 days or so. The stools are hard, dry, often skibbolous, and require forcing and straining to achieve defecation. And the relevant history is that of chronic degenerative disc disease, resulting in chronic pain. And for this, he takes a long-acting morphine, MS-Contin, 60 milligrams every 12 hours. And his dose has actually been increasing over the past year as his back pain worsens. He did not have any trouble with constipation prior to beginning opioid therapy. An abdominal plain film was done which revealed significant amounts of retained stool in the colon.
So how has he been treating his constipation so far?
Well, he's been trying to take a fiber supplement, Metamucil, and he has also been taking a PEG 3350-based laxative, Restorelax, twice daily. All of these have proven to be ineffective.
We're certainly seeing a lot of this type of constipation with the increasing use of narcotics for treatment of malignant and non-malignant pain syndromes. What is the mechanism behind narcotic-induced constipation?
Well, it turns out that opioid medications have a profound effect on gut motility, not just on the colon, but on the stomach and small bowel as well. In a previous episode, we have talked about the enteric nervous system, and by way of brief review, remember that the peristaltic reflex is the basis of all gut motility. Distension of the gut wall initiates a dual reflex arc that produces a contraction of smooth muscle behind the bolus, mediated by inhibitory neurotransmitters such as VIP, nitric oxide, and ATP. One of the important factors that regulates this neural reflex system in the gut is the endogenous opioid system. Endogenous opioids, such as the endorphins, are released mainly in the CNS and can bind on delta, kappa, or mu receptors. The delta and kappa receptors in the CNS are important in visceral pain sensation. The mu receptors are found in the enteric nervous system and, when activated, function as an endogenous brake on the peristaltic reflex. The peripheral binding of an opioid drug on the mu receptor has the same inhibitory effect on gut motility. Not only does opioid-induced mu activation significantly reduce peristaltic function, especially in the colon, it also results in increased fluid absorption from the gut. So patients with opioid-induced constipation have hard, dry, infrequent stools.
Dan, is there any difference between various opioid medications with respect to their effect on the gut?
That's a good question. And in fact, all opioid medications, whether it's codeine, oxycodone, or morphine, they all interact with the mu receptor in a dose-dependent fashion, causing this problem.
So how do you approach the problem of opioid-induced constipation?
Well, there are a number of treatment strategies that can be used. The most obvious one is where feasible to either reduce the dose of the opioid medication or discontinue the drug altogether. It may be possible to find alternative therapies for chronic pain, such as NSAIDs, physiotherapy, braces, splints, etc. However, in many of these patients, the pain is intractable and it is simply not possible or even desirable to stop therapy with opioid analgesia.
What about over-the-counter laxatives?
Well, standard laxative therapy is the next step, using products such as the PEG 3350 osmotic laxatives and stimulant laxatives such as Dulcolax and Senna. Patients need to be encouraged to push the dose, for example, taking the PEG laxative 17 grams at least twice daily, along with lots of water, and to take the laxatives daily without fail.
Are there any medications available by prescription?
Beyond this, a number of drugs have been developed to block the binding of the opioid drug to the mu receptor in the gut. The tricky part is to block the effect of the opioid drug on the mu receptor without interfering with the binding to the kappa receptors in the brain, leading to reversal of the analgesia effect. An example of this is naloxone. Naloxone, when given orally at a low dose, between 2 and 5 milligrams, antagonizes the gut mu receptor and reverses the delays in gut transit caused by the opioid drug. It has a high first-pass metabolism in the liver and theoretically at least has minimal penetration into the CNS.
Some of my patients have been started on a medication called Targan. What's that?
So Targan is a fixed-ratio combination tablet of oxycodone plus naloxone, and it has been approved by Health Canada for opioid-induced constipation. Now, while naloxone is reasonably effective in improving opioid-induced constipation, it does have a very narrow therapeutic index, and some patients have experienced both reversal of analgesia and symptoms of narcotic withdrawal with high naloxone doses. For this reason, another class of drugs has been developed called the peripherally active mu opioid receptor antagonists, or PAMORAs. These drugs, because of their chemical structure, are less able to penetrate into the CNS and do leave the analgesic effect of opioid drugs unaffected while able to block the peripheral mu receptor.
Are any of these medications available in Canada?
So in Canada, we now have a medication called naloxegol, and this is a pegylated form of naloxone. The long PEG polymer limits the ability of the drug to cross the blood-brain barrier, so it is peripherally active only. Naloxegol is marketed in Canada as Movantik and is approved for the treatment of opioid-induced constipation in patients with non-cancer pain, and it's available in a 12.5 and a 25 milligram tablet. Another PAMORA drug is methylnaltrexone, sold in Canada as Relistor. This drug is similar in structure to naloxone, but is less lipid-soluble and thus less likely to cross the blood-brain barrier. It is given subcutaneously every second day or so and has been shown to reverse the effect of opioid-induced constipation in cancer patients. And it has been approved for use in patients with advanced disease in palliative care settings.
Okay, great. Thanks for that review of opioid-induced constipation, Dan. We hope to see you next time. Bye.
Bye.